Okay, hi, good day, students. Welcome to this recorded orientation. This is for the introductory clerkship in medicine, the primary care component. My name is Shastri Motilal. I'm one of the lecturers in family medicine, and I come from the Department of Paraclinical Sciences, which is one of the participating departments in these introductory clerkships. The agenda for this recording is we'll say a little bit about what the clerkship is about, the primary care component. We'll go into the objectives, the delivery methods, the assessments, and after that, I would go into the SOAP approach to documentation, and I'll talk about some aspects of patient-centeredness. So the objectives for the introductory clerkship medicine, and remember we're talking about the primary care component of the clerkship. You will have an internal medicine component of this clerkship from my colleague in the Department of Clinical Medical Sciences. For the primary care component of this clerkship, these are the objectives. To take an accurate history from patients in the primary care setting, to complete an examination of a primary care patient, to reconcile and integrate basic sciences as it relates to patient-centered approach on a regular basis, to introduce students to the clinical environment and patients early in their training, and to utilize a team-based approach for the management of patients on a regular basis. These are the objectives that actually come from the course outline, which would be provided online on my e-learning. So these are the delivery methods and the assessment. So these delivery methods actually match the 5 objectives that is listed that I just went through. And for these objectives, the delivery method, we're going to use lectures throughout this introductory clerkship. We're going to post readings or selected resources for you all to look at. And of course, you are going to have to visit for the primary care component, make visit to health centers. The assessments that are linked to these objectives, for the first 2 objectives, we're going to ask you all to submit 4 cases, that will be worth 4%. For the 3rd objective, we're going to have an in-course 30 MCQ quiz. For the visits to the health center, you will be required to submit evidence of attendance and of course write a reflection. And the final assessment at the very, very end would be 30 MCQs as part of the final 60 MCQ question. And 30 MCQs would come from the primary care component of the introductory clerkship to medicine. The other 30 questions or 50% would come from the internal medicine guys who would coordinate the other half of this clerkship. So in terms of the history and examination, this is something that you would have been introduced to early on in medical school, reading the MacLeods, looking at how to take a history, talk to patients, and do an examination. You get to practice this at least for the first time in medical school as you interact with patients as you all go to the various clinics. And what it is, I would like to emphasize the manner in which, or one of the ways in which you could document history and examination, and of course the plan for patients is using the SOAP technique, SOAP, and I will go into that in a little bit more detail after this briefing that I'm given right now. In terms of what would be required to test the ability to know if you took a history and examined the patient is you would need to submit 4 cases, and it's 4 cases that you would need to submit, each document in a history and examination, the assessment or the diagnosis, and a plan. And the cases are to be obtained at the health centers under the supervision of the primary care physicians or the doctors who you would encounter at the primary care clinics. You may look at medical records again under the supervision of the primary care physician or the staff members at the health center in arriving at in selecting these 4 cases. And what would guide how you write up these 4 cases would essentially be there's a rubric online posted on my e-learning that would guide exactly how you're going to write up these cases. With respect to this objective to integrate basic sciences as it relates to the patient-centered approach on a regular basis, what we'll be going through for this 2 weeks in terms of the primary care component of this clerkship is we'll be going through common conditions in primary care. On the right hand side of the slide is posted 10 most common conditions that you're going to see when you all go to the health centers or go to these clinics. And we felt it appropriate for you all to get some sort of exposure to these 10 conditions. So how we plan to give you this exposure, it will be posted lectures. Some may be live, some may be recorded. And there will be posted readings for you all to actually go through over the 2-week period surrounding all these 10 conditions. At the end of the 2 weeks in the primary care component, you're going to get an online quiz that will count towards your continuous assessment. And this online quiz is going to test your knowledge on these 10 conditions, which are the 10 most common conditions we encounter in a primary care setting. In terms of the introduction to the clinical environment and appreciation of team-based care, you're going to have to visit the health center as scheduled. I will be liaising with the group leader for each group to work out the logistics of exactly how this would happen. But the intention is for each of you during the 2-week period in primary care to visit the health center on at least 4 days. So each student should have at least visited the health center on at least 4 days during the 2-week period. And you will be given an introductory letter and a sign-off sheet for attendance and assessment. So this introductory letter will state clearly who you are. You are to work with it at all times. And it also has an attendance and assessment sheet. So at the end of each day, you're going to have the doctor that you spend time with sign off on this attendance and assessment sheet for each day that you would have spent. The other way we completing this objective, apart from the health center visits and having it signed off on, is a reflection. So one of the assessments you'll be required to do is give a reflection, a 300-word reflection, at the end of the 2-week period, documenting what was learned, the experiences you had, the implications for your future practice as a young medical doctor, and appreciation of team-based care in the health centers. So whatever aspect of team-based care you were able to witness in the health center, I want you to include this as well in your reflection. There is a marking rubric that will be posted online as well to guide how to write your reflection and how the marks or points are allocated for this. So to summarize the assessments for this, it's continuous assessment. It's due at the end of the 2-week period. So you spend your 2 weeks in primary care. At the end of that 2-week period, what is due? You need to submit your 4 cases, as I mentioned before. So please remember, start working on your 4 cases from day 1. If you see cases on your first day at the health center, start working on these cases. It's 4 cases that you need. It's 4 days in the health center. It possibly may get all your 4 cases on one day, but you have 4 days to go to each clinic, and that's more than enough opportunity to get those 4 cases. So start documenting and writing down your cases early on. Don't wait until the very, very end. The exact due date, it most likely would be the Sunday of the second week in the 2-week period before you move on to the other half of the clerkship. The dates would be posted on My Learning in terms of when exactly it's due. There will be an in-course TT MCQ quiz. Again, this would be, the intention is for it to be facilitated online through My e-learning. This would be a timed exam, and you'll have a window period to complete this timed exam or quiz. The evidence of the attendance, the sign-off sheets that I mentioned that everyone will be given, you are to submit that as well through My e-learning. There will be a link for you to submit this. And your attendance, of course, is worth 3%, right? We want to see that you attended on at least 4 days, and the doctor signed off on the brief assessment at the end of each one of those days. And there will also be a link for you to submit your reflection at the end of the 2-week period. So these links to make these submissions and to do the quiz will be present on My Learning, and you will have access to it with clear dates defined on My e-learning. In terms of the final exam, it will be due at the end of the 4-week clerkship, right? So remember, this is part of the introduction to medicine clerkship, the primary care component. So at the end of the period, you would have an exam, and it will be an MCQ exam. That exam would test, of course, what you learned over the 4-week period in the introduction to medicine. So it will test your primary care aspects, which is what I'm talking to you all about in this briefing, and it would also test what you learned in the internal medicine aspect of the course. So with that briefing, and of course, I would entertain any questions people may have in terms of queries and things you're not unsure about. I'm sure you all will have queries or things you're unsure about. So we'd have a session live where we have the opportunity to address any specific questions. But what I would like to do now is go into the details of how to document notes. What it is I'll introduce you all to is what we call the SOAP notes and elements of patient-centeredness. And this is something that is not specifically unique to the primary care aspect of the clerkship. You could probably apply this to all the clerkships that you would encounter, the medicine aspect of this clerkship, the surgery clerkship, even the other clerkships when you all go into the clinical years. How we document our notes and elements of patient-centeredness, you would learn could be applicable to everything. So this is just to give you a framework of how it is you could write down your notes. And this is how you'll be documenting notes as a doctor, most likely, in most specialties. And I also want to tie it into something important to us in primary care called patient-centeredness. So we'll see a little bit about what this actually entails. So what's the SOAP note? The SOAP note is a way of documenting a medical encounter. So it stands for subjective, objective, assessment, and plan. And as I said, it's one way of documenting a medical encounter. It's not definitely final. There are many other ways of documenting medical encounter, but this is one of the popular ways that you could follow at this stage. Following this at this stage definitely would be complete and accurate enough for you guys at this level. And it's really to add structure and organization to how you write your notes up. You know, when you see a patient and doctors have to make notes about it, it adds structure to it. And it also is important because it could guide healthcare workers on the use of clinical reasoning. And it's kind of like you could think of it like a checklist type way of documenting things for completeness to make sure you're documented everything after you see a patient. So what's subjective? Subjective is the presenting complaint. So the chief complaint, patients come and say, Doc, my back is hurting. That's the chief complaint or the presenting complaint. And it could be a symptom, Doc, my back hurting. It could be a condition, doctor, I'm here because I have diabetes and I just come today because you all told me to come back in clinic. So the person may have been given a previous diagnosis. That could be something that the patient actually stated. Or it could be another reason why the patient came. Sometimes patients come to us because, Doc, I'm here to fill an NIS form or I'm here to get a sick leave for seeing the doctor last week. So this is subjective because it's based on what the patient actually said. A patient may actually have multiple chief complaints. A patient actually said, Doc, you know, I'm here today because my back hurts, but I also want to get a sick leave because I was unable to work. So definitely it could have more than one. Anytime a patient gives you, of course, multiple presenting complaints, I have patients and will come and say things like my back hurts and I'm getting a rash on my foot, and I would also like to do a blood test to make sure I don't have diabetes. That's 3 things the patients actually say. It's always good to list them, and it's always good when patients have multiple complaints to list them in order of priority. Doctors sometimes feel intimidated when a patient come and they say they have 5 different things bothering them. They get confused, flustered. What do I deal with? What do I document? You're expected to document all, but it's helpful to ask the patient sometimes, all right, you told me 5 things today going on. Help me put them in order. Which one bothering you the most? And the patient would say, well, actually, doc, this back pain is really what troubling me the most. So it's always helpful to ask the patient if they have more than one chief complaint to prioritize them for you. When you look at the chief complaint, especially if it's a complaint like back hurting, back pain, I keep using that as an example, you want to find out when did it start? Where exactly is it? Duration, how long it going on for? And when you talk about duration, it's important to find out if a symptom is intermittent, if it's coming and going. The person might say, well, I had back pain this morning, it lasted 2 hours. but the person really was getting back pain for the last 2 weeks, coming and going. So when you talk about duration, you have to consider that when you take a history from your patient. Duration is also applicable to the entire duration the symptom has been going on for, as well as, especially for intermittent symptoms. Is it changing? Is it getting better? Is it getting worse? You always ask the patient to describe this to me. If a person is describing pain, describe the pain. What does it feel like? Can you describe it without using the word pain? Asking the patient, alleviating, aggravating factors. If the person said, "Doc, my head hurts," ask, "Does anything make it better? Does anything make it worse? Does the pain move anywhere?" Right? You're having pain in the head. Is it at the front of the head? Does it radiate all the way to the back of the neck, down the shoulders? Tell me about the pain. Temporal factor, anything makes it better or worse. If a person says they get headache worse in the night when they sleep and get up, the headache waking them up in the night, that's actually a red flag for headache. You're thinking that could be increased intracranial pressure. That could be something serious. The severity, especially when a person describes pain, you want to ask them on a scale of 1 to 10, 1 being the least, 10 being the worst, how much would you rate it? And the interesting thing is you must do this for all the chief complaints. So if a person has 5 complaints and you have to do this for all 5 complaints, you could bet that it could get kind of tricky and difficult to actually document this. So it's important to have some sort of structure or framework to help document notes, which is what we're talking about here. In terms of subjective, so we're still under subjective. Remember, it's SOAP, SOAP, subjective. You want to find out the history in terms of what the person say they had before. You want to find out if the person say they had a surgery. You want to find out about their family history. It's important to ask about the social history, and there are different aspects of the social history that is listed here that we could ask about. I wouldn't go into the nitty-gritty details of all of these. They're more or less kind of self-explanatory. But note that all of this is still subjective. So you are asking the patient what they think run in the family, or if they had surgery before. Of course, you could verify that a person had a surgery if it's documented in the notes. So if you could pull that chart and get that record before, in which case that past record saying the person had, let me just say, a hysterectomy 2 years ago with details of the note, that would be an objective finding. But here we under subjective. It's what the patient is reporting and say they had for these headings seen on your screen. Review of systems. Review of systems is something you all may have been introduced to when you started reading the MacLeods and talking about taking a history. It's a system-based approach to uncover symptoms not otherwise mentioned. So a person might say, "Well, doc, my head hurts." And you might want to ask them about other things relating to your head, relating to the neurological system. You might want to ask them if they ever had a history of headache before in the past, if they had seizures, if they have depression, if they have problems concentrating. You may want to ask things around the neurological system if the person presented with headache. If a person come and said, "My belly hurts," you want to ask them things about weight loss, decreased appetite, if they're vomiting. You want to ask them about the other aspects of the gastrointestinal system. So usually review of systems, what questions we ask is really directed based on what the presenting complaint is. If a person comes and they say, they get in shortness of breath, you want to ask about chest pain, you want to ask about wheeze, you want to ask about palpitations, you want to ask about, anything that makes the short breath better or worse. So you'll want to focus on the cardiovascular and respiratory system and a person complaining of shortness of breath under review of systems. It may not be so important that you explore everything, all the review of systems like the endocrine system or the skin, but you might learn soon in medicine that everything is related with the patient. It's very difficult to separate systems once you start talking to patients. And in primary care, you will definitely be able to appreciate that patients may come with a symptom suggestive of a problem with one system, but it might be related to another system. So a review of systems, knowing all the questions to ask for all the different systems in the body, definitely is helpful at this stage. Of course, we ask about medications that the person is taking and allergies. Now, what's objective? So subjective is what the patient tells you. It's subjective in that you may not be able to verify it. It's just based on what the person reports. If a person says my back hurts, there's no way for you to prove or disprove if their back is hurting them or how much it is hurting them. If a person comes and says, "Doc, my head hurts," there's no exact way I could figure that out. But objective says that there are ways that we could try. So objective are things that we could measure, and objective signs, things that we could go with. So these are the objective features. So the vital signs, the blood pressure, the pulse, the respiratory rate, the temperature, the SpO2, they are the things that we could measure on a patient. So a patient might say, Doc, I feel short breath, but the respiratory rate might be 12 breaths per minute. The oxygen levels might be 99%. Their pulse might be 90. And that's very different from a person complaining of shortness of breath with a pulse of 130 and a SpO2 of 88%. So vital signs are ways we could objectify what patients tell us. And vital signs is one of the basic things we use when we examine patients in medicine. It's the first thing we usually document when we document the examination findings. We always document vital signs because they're very important and they could give us important clues as to how sick a patient is, which tells us about the acuity of the case, how acute it is, and how quick we need to act. The next objective aspect is the physical examination finding. So a patient might say, Doc, I feel shortness of breath. But the next thing you could do is when you examine them is you could look at them and look for signs of respiratory distress. So signs of respiratory distress would be the objective way of trying to figure out how bad this person's shortness of breath is. And usually there's some sort of physical examination finding that you could use to objectively kind of like figure out what the patient told you subjectively. A person might say, Doc, my head hurts, my headache is really bad. The physical examination finding might be that this patient appears or seems to be in painful distress. The person might be actually holding the head and actually grimacing in pain, whereas another patient might say the head hurts, but they seem comfortable and they sit down watching you cool, and everything looks normal. The physical examination finding, again, for someone with headache, one of the things I always check for is tenderness. I feel the scalp, I palpate their scalp. Physical exam findings is what you're doing in the skills lab from year one and the things you're learning about, how to examine the cardiovascular system, how to examine the respiratory system, how to examine all the systems. And of course, the examination findings you look for would be based on what the patient present with. So whatever the patient complained of subjectively, the exam findings is what you're going to emphasize on. Laboratory data. This is objective in the sense that if the lab says a person is anemic, they review a blood count, it shows that the hemoglobin level is low. That's laboratory data. And that is something objectively you could refer to. You could refer to a number on a blood test or a lab finding. Same thing for imaging result. If a person have an X-ray report or a CT scan or ultrasound result, these things are objective. You could refer to it and look at it. Other diagnostic data too that the patient might bring, like we just said, they do a biopsy, they have a histology report, that would be diagnostic data. The other thing that could be objective is recognition and review of documentation of other clinicians. Other doctors could actually write down what the findings were when they examine the patient. And often when we see patients on a continuum, you probably chances are the patients you all see may not be the first time the patient is coming to the doctor. It could be maybe the patient coming every 3 months to the doctor in chronic disease clinic. So looking back at the documentation, the person would say, well, the doctor gave me some sugar pills, that's subjective. But the objective would be, you look at the notes and say, well, all right, the doctor did prescribe metformin and glycoside at the last visit. So that would be objective when you look at documentation or notes from other doctors. Sign or symptom. So if a person says, Doc, she states she has stomach pain, what section this should go in? Subjective or objective? If the person is saying, I have stomach pain, well, that should be subjective because the person is saying, my stomach hurts. If you find abdominal tenderness to palpation, what section this should go in? Abdominal tenderness to palpation is an examination finding. So keep in mind, examination findings are different from symptoms. Symptoms is what the patient complain of. It's always usually under the subjective aspect or the history. Signs are what you elicit on examination. So abdominal tenderness to palpation would be an objective finding or an examination finding, right? So as we keep saying, symptoms are often subjective, but physical examination is a way to objectively validate the symptoms that our patients complain of. So SOA, assessment. So what's the assessment? The assessment is your interpretation of the subjective and the objective. You listen to what the patient have to say, you ask them questions, there's a history, you examine them. Now you're going to come up with a problem list or a diagnostic list. And this do have to be something exact. If you have a diagnosis in mind, so if the person have abdominal pain and you thought they had epigastric abdominal pain and you want to put query peptic ulcer, you could put query peptic ulcer. If you're unsure as to the cause of the pain, you could say the problem is epigastric pain, acute epigastric pain, query cause. In medicine, you'll soon learn in your clinical clerkships, we try to put a diagnosis as much as possible, and the diagnosis is something that you should suspect strongly after your history and exam. Nothing is wrong with listing a query diagnosis, query peptic ulcer disease, to find out later that you were incorrect or wrong and the patient had gallstones or the person had pancreatitis. But it's important to at least sometimes put a diagnosis so it alerts other doctors and other clinicians as to what you were thinking. It could also be a differential diagnosis. You could say, well, I think I'm peptic ulcer disease, but I want to rule out pancreatitis. So the differential diagnosis and the problem list we come up with must be, of course, for each of the chief complaints. So obviously, if a patient came with back pain and abdominal pain and a rash on the foot and they're concerned that they have depression, you have to put a problem list or a differential diagnosis for each of these chief complaints, right? If there's one diagnosis that could explain all the symptoms, then fine. But sometimes when patients have multiple symptoms, sometimes there can be multiple diagnoses. And if there are multiple diagnoses or multiple differentials, assessment is where you list them out. The P, SOAP, is the plan, is what you're going to do. What you're going to do now as a doctor. The plan is where you decide what is going to happen next. Is where you actually say, well, I want to send the person for this test. And you want to send the person for a test based on what you think could be wrong. So if you saw a person with epigastric pain, you thought they had a peptic ulcer disease, but you wasn't too sure if they could have gallstones. Gallstones could cause biliary colic, which could cause epigastric pain. And you wanted to give the person treatment, a therapy for the ulcers, but you wanted to send them for an ultrasound to just make sure there isn't anything else like gallstones or the pancreas looks healthy, then you could put that in your plan. Your plan is what test you're going to do and send the patient for. Obviously, your plan must be in keeping with the A in SOAP, with the assessment that you just came up with. The plan, of course, includes therapy, and therapy could not only be a medication, it could be physiotherapy, it could be non-pharmacologic treatments. If the patient came with lumbosacral strain or muscle strain in the back and the doctor recommended heat, a heat pad applied to the area, or the doctor recommended that the person do certain exercises or see a physiotherapist, that is a therapy, it is a treatment. Treatment isn't always a medication with a dose or a pill or a tablet or an injection. The plan also includes if the doctor going to refer the patient to someone else. So if the doctor say, well, I think this is something serious, I want to send it to emergency, that's a referral. Or the doctor is recommended, well, I want you to consult with a urologist. I think you're having a prostate issue that requires further attention. Then that would be part of your plan if the doctor is going to refer the patient. Of course, the plan also includes things like patient education and counseling. So if the doctor counseled the patient briefly, the patient was feeling depressed and he gave some sort of brief intervention to counsel the patient. If he did motivational interviewing to help a patient quit smoking, if he gave general education, we just say the patient came in with concerns about the COVID vaccine, that would be patient education regarding the vaccine. All these are the things that we do to help the patient. All this is part of the plan. So considerations with the SOAP technique. Sometimes if you're looking at ongoing care, so if a patient came to you and is like, doc, well, I have diabetes, I always in the clinic, I'm known to have diabetes and hypertension. I'm seeing doctors for the last 10 years. So if it's ongoing care, the patient come for many, many times, it's not the first visit, you may want to put APSO. You may want to look at the assessment, what was done at the last visit, what diagnoses the patient got, especially if it's a chronic disease. Often chronic diseases like diabetes and hypertension not going to change, they're going to remain with the patient for life. You want to probably see the plan, what the last doctor recommended. Say, well, all right, the patient assessment, the patient had a diagnosis of uncontrolled diabetes. The doctor decided to add insulin to the patient's regime or add on extra sugar pill. That was the plan. And the subjective would be, well, how are you going now? What is happening after the doctor did these things at the last visit? Then the patient might pull out their book with the sugar readings and they're showing you something objective. So that's a documentation of a sugar reading. So the SOAP technique can be changed to disorder, assessment plan, subjective, objective, especially if you have a patient for chronic disease care or having ongoing care. It's not so much the order it's important, it's that these things are addressed when you write up your SOAP notes, right? Once you have some sort of documentation that there was an assessment, a plan, some subjective kind of information, what happened with the patient, and some sort of objective way of verifying that, that actually completes your SOAP note. SOAP may be very good at documenting changes over time. It may not always be. Evidence may change over time. Sometimes the way we treat certain conditions may change. The plan for certain conditions may change over time. And if a patient was getting a particular treatment as part of their plan all the time, if there is a new treatment approved now, that plan may need to change. So remember, the plans that sometimes you would see in the notes for a patient being treated for diabetes, that might change. It's definitely not set in stone. The focus of SOAP, though, this model is it focuses mainly on the biomedical model. The biomedical model say when you see a patient, they could have a particular disease, you're going to use your understanding of the body and what's normal and all the things you're going to study in medical school, what's normal, what's abnormal, what's pathology, figure out what's wrong, come up with a diagnosis, treat the patient. That's the biomedical model of medicine, which we still largely practice today and which is there's a great emphasis on in medical school. But the biomedical model is something that could be enhanced and is something that could be improved by using this aspect, which brings us to patient-centeredness or patient-centered consulting. So what's this thing called patient-centered consulting? Patient-centered consulting actually states when we see a patient, we go through the biomedical model, we take a history, do an exam, we go through everything in SOAP that I mentioned, but we also address certain things, and there's also a way in which we kind of put together the plan and we tell the patient what's going to happen. So the patient-centered consultant is an additional framework that you could use in addition to the SOAP model to improve how you deal with patients, how you care for patients. And evidence have shown that if you are patient-centered in your approach, if you are patient-centered in your interactions with the patient often feels better, they feel happier, they're more likely to stick to the plan you're going to come up with as part of the SOAP approach, and they're more likely to return and follow up. And things just generally go so much better when you are patient-centered in your approach. Patient-centeredness is a big thing, of course, in primary care. It's one of the strengths that we have as primary care physicians because of the relationship we develop with patients, but it's by no means something exclusive to the primary care component of this clerkship. You could do patient-centered consulting in internal medicine, in any other specialty in medicine. It has its role, it has its limitations. It's not too important or takes so much prominence if you have a patient with an acute emergency in a life and death situation presenting in the emergency room. But it definitely has a role when you have to provide longitudinal care to patients over a period of time, which is something you will typically see as you go through the primary care aspect of this clerkship. So what's patient-centered consulting? There are 6 elements. The first element is we explore the disease, but we also explore the illness. So what I mean when I say we explore the disease, that is what we were talking about all the time actually. When I spoke about the chief complaint and the things you ask about the chief complaint, and then you examine the patient, all of that is surrounding the disease. You are not at the stage where you're learning pathology as yet. You're going to learn that in your next year. But you will get exposed to some pathology as you go through these introductory clerkships, which will be a great learning experience for you. If you see some sort of disease throughout these next couple of weeks, that would be great. But the patient-centered consultant says that we don't only explore the disease when we see a patient, we don't only take a history and then do an exam, we also explore the illness. So the illness is this thing called FIFE, F-I-F-E. And FIFE says when we see a patient with a particular complaint, we look at their function, we look at their ideas, we look at their feelings or concerns, and we look at their expectations. The order is not too important. It's feelings, ideas, functions, expectations. There is no specific order, but it's important to address these aspects when we see a patient with this, with any complaint. So if a person comes and say, well, doc, I have back pain, you talk to them, you find out is 9 out of 10 pain is in the lower back, is worse when they bend down, is worse when they move. They lift up something heavy 3 days ago. You're thinking there's muscular strain, you have explored the disease, you examine them. The illness exploration for that could be asking the patient, well, tell me, feelings, concerns, how does this concern you? Anything in particular you're worried about? Ideas, what you think this could be? What you think this back pain is? You say it happened after you bend and lift up something. You think it was related? Patient might say, well, no, doc, I thought it was something bad. I had a friend who had cancer and they had pain in the back. I actually thought this thing was cancer. That could be the patient ideas. Functions, how is this affecting you? How is this really troubling you? Since again, the back pain, you're able to do your work at home, you're able to go to work, you're able to complete your normal routine chores. Do you have any expectations? Is there anything you feel we should do about this? Is it that today you came today thinking we need to send you for a CT scan for this pain in your back? You think we need to do an x-ray? What you was hoping to get out of this visit when we come today? That's a quick example of how we could use five or exploring the illness in a patient presenting with lower back pain. And you could bet we could have 5 patients with the same exact medical diagnosis, but the illness experience would be completely different or maybe completely different for these 5 different patients. 5 patients could all have lumbosacral strain. One patient could think, well, yeah, I kind of figured after I lift up those heavy things, that's why my back hurt. Another patient might think, well, I think it's cancer. A next patient might think, well, doc, I think we need to do an x-ray to figure out what is going on. Another patient would say, like, doc, well, I okay with the pain, eh? The pain not so bad. I really come in today because I want sick leave. I just want to stay home and rest for a couple of days. The pain not so bad. I just want to stay home. That's their expectation. So different patients come with different illness experiences, even when they have the same disease. So it's important to explore the illness experience for different patients. Understanding the patient as a whole. This is a big thing in patient centeredness. We don't see patients as just people, organ systems, a collection of organ systems just walking around. A patient is more than just a collection of organ systems, all the organ systems you all would have learned about so far in the past 2 years. A patient has organs, yes, but they also have feelings, they also have family, they also live in a particular place, they also have relationships, they also have a job. When we try to understand patients as a whole, sometimes I would tell a patient, if I meet them for the first time, tell me a little bit about yourself. And the patient might say, oh, doc, I'm a parent of 2 and I'm a mommy, I'm a stay-at-home mom. Or they might say, oh, doc, I'm a busy guy, I'm working, I'm trying to finish my school and I'm trying to do my job at the same time. I hope to go into this particular field later on in life. You'll get different answers when patients actually we ask this question. But as a doctor, we should try to understand patients as a whole. Another easy way to figure this out is to tell the patient, ask the patient, tell me what a typical day is like for you. Today is whatever day of the week it is. Tell me how this day went, what you did, how the day started, how your typical day ends. And the patient would give an example of what it is they do on a daily basis. And that paints an idea of what this patient is or who this patient is in front of you. We also find common ground. Finding common ground means the patient and the doctor agree on what happens next. So you might say a patient again with back pain, and you say, doc, my back was hurting. And what would happen is you could say things like, well, I think this is lumbosacral strain. I know earlier on you was telling me we should do an x-ray. I might tell the patient, well, x-ray often don't diagnose a strain. A strain is where the muscle gets affected, but muscles don't show up on an x-ray. So what it is I would like to do is try some medications for you. If the pain don't get better, we could maybe consider the x-ray at a later time. What you think about this? And if the patient says, oh, doc, well, that sounds reasonable. If you say the x-ray wouldn't show anything, I'm happy trying the medicines and seeing how it go. If it don't get better, you come back and I could tell you about it. So you're trying to agree on what it is going to happen next. Gone are the days where the doctor would just order the patient and tell them, here what, I want you to do X, Y, and Z. The patient have absolutely no say in what happens next. That may work in an emergency situation. Person come in life and death, barely conscious. The doctor need to tell the patient to do and dictate what's going to happen. But except for emergency circumstances, usually if you see a patient and they have to go and come back or do some tests, or you see them over a period of time, finding common ground is definitely something that we try to do in primary care. Enhancing the doctor-patient relationship. So when we enhance the doctor-patient relationship, we do things to actually improve the trust in the relationship, improve the tendency for patients to want to disclose certain things towards the doctor. Enhancing the doctor-patient relationship definitely helps. We incorporate prevention and health promotion. So prevention and health promotion says a person might come to me with back pain, again I use that as an example, but it might be a 53-year-old lady, and I might find out that the lady never had a pap smear, or never did a mammogram, or never did a colonoscopy, and I might use this as an opportunity to address the back pain, but tell the patient, well, you know, these are other things that could make you sick. If you never addressed these things before, it's something that maybe we could consider, you know. And the other thing we like to figure out of as well is being realistic, or in practice, we like to be realistic with patients. So sometimes a patient might come to me and say, Doc, I want to do a blood test. I say, what kind of blood test? I say, well, I want to do a test that will tell me if everything in the body working okay. And I would be realistic with them and tell them, well, there is no one test that could tell us if everything in the body is working good and fine. I could do a blood test to diagnose diabetes and high cholesterol, but a blood test wouldn't tell me if the muscle in your back is pulled. A blood test may not tell me if you have a breast cancer. So we often have to be realistic with patients in terms of what could be done. We often have to be realistic with patients in terms of time. So sometimes a patient might come and say, Doc, you know, I have all these complaints. How are you to fix everything? That is why I come today. And I would say, all right, okay. You identified 5 things. These are the 5 issues that troubling you. But today I only have 15 to 20 minutes consultation time to deal with you. I would like to address the ones that bugging you the most, but I may ask that you return at a later time for us to address the less pressing issues. So this is what I would actually like to do. That is me being realistic with the patient, because I know I can't address all the problems and solve all the issues in one visit. Right? So mutual decision making. So these 6 aspects are the 6 aspects of patient centeredness. And this is what we try to do together with the biomedical model. And it's something you will come to appreciate as you go through your other clerkships. If you practice some aspect of patient centeredness, even with the patients you will see over the next couple of weeks, people would remember you for it. They would say, well, that doctor actually cared. He asked me things about how this thing affected me, what my ideas are about it, what it is I was hoping to get from coming to the clinic today. He actually asked me questions about my own life, and the advice he gave me was in keeping with what I told him. He gave me personalized advice. So patient-centered consulting works, right? So the doctor-patient relationship, we try to, of course, care for patients, show them compassion. Power dynamics has to do with, you know, who has more the upper hand in a doctor-patient relationship. Is it the doctor more powerful than the patient? Is it the patient more powerful for the doctor? We usually try to go for equal power sharing in the primary care setting, where the doctor and patient could come to a mutual agreed understanding. Sometimes the patient expect you to be paternalistic, and they expect you to be, doc, I really don't know about this. I come to you, the doctor, you tell me what to do. You just tell me what to get done and I will do it. Sometimes the patient come with the expectation that they have more power. So, doc, you know, I miss work. I want to get a sick leave. You know, you have to give me the sick note. You know, I'm paying you for this visit. You know, you should give me the sick leave. So then the patient is probably the one exerting more power in a situation like that. So we often have to be aware of these things, like these dynamics that come to play when we consult with our patients and select or decide which is more appropriate. Self-awareness is also important too, for you as a doctor to be aware of yourself as a patient, as a provider of care to patients, and be aware of your own thoughts and emotions and feelings as you consult with patients. You'll learn about the doctor-patient relationship in a little bit more detail when you go into the consultation, in a little bit more depth when you come into the primary care setting again in year 4 in medical school. This is what we said when we explore the illness. We said we look at the feelings, the ideas, the functions, and the expectations. And you know what? You should do this for all the chief complaints. So each of the complaints, you need to explore the illness in addition to exploring the disease and document it. Integrating disease, illness, and the whole person. So this is where we consider the patient's personality. We consider the cultural background. We consider what stage in life this person is at. We consider patient's spirituality and what it means to them. We consider the family dynamics, who they live with, was the relationships with the other people in the household. We consider actually all these things when we actually treat a patient, and that is what patient-centeredness actually says that we should do. Finding common ground. As I said before, this is where we agree with the patient on what are the issues, what are the problems that need addressing, what it is we're trying to achieve, how it is the treatment we're going to give, and rules, who's going to do what. Finding common ground or mutual decision making is what we try to accomplish. We say we try to accomplish health promotion and prevention, and this involves, of course, some concepts you may be familiar with. Primary prevention. Primary prevention actually states the things we're going to do to stop the person from getting sick, like giving a vaccine for COVID to prevent the person from getting infected or to prevent severe disease, or giving other vaccines or educating the patient. Screening or secondary prevention. This is where we try to detect diseases at an early stage. So when we screen people for cancers, like send them for a mammogram or do a colonoscopy or send them for some sort of test to detect, the sugar level, screen them for high cholesterol or diabetes, or do a pap smear. This is all screening or secondary prevention. And all this is really trying to reduce the risk and encourage a healthier lifestyle. A person might come to me with, again, lower back pain and they have muscular strain, but that's going to get better. Most people are going to get cure on their own, even if they don't see a doctor within 2 weeks. But you know what? If I found out that patient smoked and I did not give them advice, the smoking might kill them with a heart attack or a cancer. If I didn't advise the patient to follow up and go and do a colonoscopy, maybe they have a polyp that's growing inside the colon that may actually develop into a cancer in the next 2 years. Seeing them today for the back pain was an opportunity to address these other aspects of, of their medical care. And of course, as I said, we'd be realistic. We try to use time. We agree on the goals that we could agree on. We try to say, this is what we're going to treat you for. This is the diagnosis that we come up with. We have to be realistic with what we could accomplish with the resources that we have. As you all go into the primary care setting, you'll realize the doctors ain't have access to a CT scan or an ultrasound or fancy tests. So often in the primary care setting, doctors have to be realistic about what they could accomplish and what they cannot accomplish. If they need to refer the patient for further testing or treatment, what they need to do. So how does patient-centeredness fit in with the SOAP notes that I actually told you all about? Well, on the far right, there are the different aspects of patient-centeredness that I just went through. The doctor-patient relationship, building and improving it, exploring the illness, integrating disease, illness, and the whole person, health promotion and prevention, finding common ground and being realistic. So how does this fit in with SOAP if you had to write down aspects of patient-centeredness in your chart when you record it? Well, the doctor-patient relationship, how we build on that, exploring the illness, tell me what you think going on, how is this affecting you? That's subjective. So those aspects could be included under the S, under the subjective when you write up your notes. If we had to integrate disease, illness, and the whole person, that would be something objective. So we're telling the person, well, this is the diagnosis, this is what we think is wrong, this is what's happening. So we considering the disease and we telling the patient, well, this is what's going to happen next. The assessment, we come up with a diagnosis, and the assessment is what we think is wrong. And what we think is wrong, the assessment, we could be realistic with what we think is wrong and what it is, the diagnosis is. And of course, the plan could integrate all these aspects. Part of our plan could be exploring the illness and considering the illness and treating the patient. So if the person say, well, doc, I think you should do a scan, part of the plan might be, well, we could send the person for a scan if the pain doesn't get better within a week. Or part of our plan would be the person came for back pain, but I also asked them about smoking cessation and I gave them smoking cessation advice. And I also recommended a mammogram to them. That was part health promotion and prevention. Part of the plan, of course, would also be finding common ground. And part of the plan could also be being realistic. So these aspects of patient-centeredness actually isn't really alien to the way in which we could document our notes. And as you'll see in the rubric for when you all write up your 4 cases, you're writing up your 4 cases based on the cases you see and based on the cases that grab your attention in the clinics. You could get the permission of the doctors when you see the patient to ask the patient other questions. You could chat with the patient once the patient gives permission to do so before or after the doctor is seeing the patient. And you could even ask to look at the patient notes, get permission from the doctor, or ask the doctor, what's the plan? What it is you do for this patient? I just need to list it out. What it is you thought was wrong with this patient to document your assessment. And these are the bits that you document in as you sit and see the patients with the doctor in the primary care setting over the next 2 weeks. All right. So with that, I say thank you. I know this is a recording of this orientation, but of course you will have an opportunity to ask questions and clarify things about what we spoke about first in the briefing, and as well as on the SOAP notes and the patient centerness. So I thank you for your time and attention, and definitely I would be happy to take your questions when we meet up for the brief um, orientation at the beginning of the 2 weeks.